Postpartum care. The puerperium is the period beginning after delivery and ending when the woman's body has returned as closely as possible to its pre-pregnant states. This period approximately 6 weeks. We have some physiological changes in the puerperium that we should know. Uterine changes. The fundus is usually midline and about the level of the woman's umbilicus after delivery. Within 12 hours of delivery, the fundus may be 1 centimeter below the umbilicus. With each successive day in the puerperium period, each day the uterine descends 1 finger breadth, reaching the pelvis at the 10th postpartum day. So it's no longer palpable abdominally. This is what we say. The Leukia is the vaginal discharge that happened in the puerperium. It is consisting of fatty epithelial cells, shreds of membrane, decidua, and blood. It is red in color in the first 2 to 3 days. It's called Leukia rubra. Then it becomes pale or brownish color. It is called Leukia serosa. It happened between the 3rd to the 7th or the 10th day. Then it became a whitish or yellowish in color, Leukia alba it's called, and it continues for about 3 weeks. The vaginal walls, uterine ligaments, and muscles of the pelvic floor and abdominal wall regain most of their tone during the puerperium. Postpartum diuresis occurs between the 2nd and 5th postpartum days as extracellular water accumulates during pregnancy begins to be excreted. Third spacing اللي صار بالpregnancy بيرجع على circulation. If urinary output was obstructed because of the pressure of the presenting part. With loss of the placenta, circulating levels of estrogen and progesterone decrease while levels of prolactin increase, thus initiating lactation in the postpartum woman. Colostrum is a yellowish fluid containing more minerals and protein and immunologic component like IgA, but less sugar and fat. It has a laxative effect on the fetus or in the infant after delivery. It is secreted in the first 2 days postpartum. It is minimal in amount, but it has a very good quality. Mature milk secretion is usually presented by the 3rd postpartum day, but it may present earlier if the woman is exclusively breastfeeding and if she breastfeeds immediately after delivery. Breast engorgement with milk, venous and lymphatic stasis, and swollen, tense, and tender breast may occur between day 3 and 5, especially if the breastfeeding is minimal. What we should assess in the postpartum period, we should assess for postpartum hemorrhage. This is the most serious one. It's started to happen immediately after delivery. We should assess the firmness of the fundus at regular intervals to detect uterine atony. We should inspect the perineum for frank bleeding. We should assess the color, amount, and odor of the leukia. We should count the perineal pads if they are soaked or not. We should assess the vital signs at least twice daily and more frequently if indicated. We should assess the bowel and bladder function. We should assess for breast engorgement. We should assess the perineal incisions like episiotomy for signs of infection. We should inspect the legs for signs of thromboembolism. This is very important. And we should evaluate the interaction and care skills of the mother and the family with the infant. sign. This is the Homan sign. It is a calf pain during dorsiflexion of the leg or of the foot. This is a sign of venous thromboembolism. Postpartum blue or depression. Um, Many women may experience temporary mood swings during this period because of the discomfort, fatigue, exhaustion after the labor and delivery, and it happened because of the hormonal changes, mainly decrease in estrogen level. Um, some mothers may experience the blues um, at about the third postpartum day, irritability, poor appetite, insomnia, tearfulness, and crying. This happens in almost 70% of mothers. This severe or prolonged depression is usually a sign of more serious condition. Depression can happen in 10% of mothers, and it has more severe symptoms of the blues, more than the blues. Why postpartum blues or depression happen? Because we have difficulty in coping with the physical changes and the discomfort that happened after delivery, uh, because of changing the family relationships and meeting the needs for family members, including the newborn, emotional stress, feeling of isolation, a lack of time for personal needs and interests. Even the whole new environment that happened to the mother is the cause. Postpartum fever, or what's called puerperal sepsis, is defined as fever more than 38 Celsius on more than two or more occasions, 6 hours apart, excluding first 24 postpartum first 24 hours in the postpartum period. In day zero, the most common cause is atelectasis. Risk factors is the general anesthesia, incisional pain, like cesarean, and cigarette smoking. Mild fever with mild rains on auscultation. Patient is unable to take deep breaths. Management is pulmonary exercise with incentive spirometry and early ambulation. Just X-rays are unnecessary. In days 1 to 2 postpartum, UTI is the most common. Risks multiple catheterization and vaginal exams. Findings are fever, costovertebral flank tenderness, especially if we have an upper UTI, abnormal urine analysis and urine culture. Um, Intravenous antibiotics is the treatment. From day 2 to 3, the most common cause is endometritis. Uh, Endometritis is the most common cause of fever, or the most common cause of puerperal sepsis in general. Risks emergency cesarean after prolonged rupture of membrane and prolonged labor. Moderate to high fever with uterine tenderness. Peritoneal signs should be absent and peristalsis should be present. Management multiple agent IV antibiotics like gentamicin and clindamycin to cover the polymicrobial genital tract flora. Postpartum day 4 to 5 wound infection. Emergency cesarean after prolonged rupture of membrane and prolonged labor is the main risk factor. Spiking fever despite antibiotics, along with incision signs like wound erythema, drainage of the disc of the wound, and then management with IV antibiotics. We should do wound drainage, um, wound packing used for an abscess. طبعا closure by secondary intention. Septic thrombophlebitis can happen starting from day 5 to 6. Um, Risks emergency cesarean, prolonged labor, persistent white fever swings despite broad-spectrum antibiotics. Management intravenous heparin for 7 to 10 days, keeping the PTT values at 1.5 to 2 times baseline. Day 7 to 21, infectious mastitis, lactation and nipple trauma leading to nipple cracking and allowing Staphylococcus aureus bacteria to enter breast ducts and loops. In clinical findings, fever of variable degree with localized unilateral breast tenderness and pain and erythema. Management oral cloxacillin, breastfeeding can be continued. Ultrasound imaging is needed if we have signs of abscess, and the signs of abscess is very severe pain, more localized tenderness. The mastitis itself does not respond to antibiotics. This is a sign of abscess, so we should do an imaging. And the reason why we should diagnose abscess, because the intervention may be different from just simple mastitis. We may need surgical intervention. Postpartum endometritis is the most common cause of puerperal sepsis. Cesarean, as we said, cesarean section, prolonged rupture of membrane, prolonged labor, multiple vaginal exams, all are risk factors for postpartum endometritis. The pathogenesis of this infection involves inoculation of the amniotic fluid after membrane rupture or during labor with vaginal microorganisms. The myometrium leaves of the broad ligament and the peritoneal cavity are then exposed to this contaminated fluid during cesarean delivery. The reported incidence after cesarean is less than 10% in patients receiving appropriate antibiotic prophylaxis. These are the risk factors, as we said before. Clinical symptoms: fever, chills, abdominal pain, foul smelling, pus containing leukia, and it may present as headache. Antimicrobial prophylaxis is associated with a 50% reduction in infection in all populations studied. All patients undergoing cesarean delivery, elective or emergent, are candidates for antibiotic prophylaxis. When the antibiotic should be given just before skin incision rather than after the incision, the incidence of post-cesarean infectious morbidities are decreased without adversely affecting neonatal outcome. Treatment is the cause of endometritis is polymicrobial, caused by the vaginal flora. Examples are the group B strep, Enterococci, Gardnerella vaginalis, E. coli, bacteroides species. They are the most common endometrial isolates, with the group B strep and Gardnerella vaginalis the most common isolates from the blood. Clindamycin plus gentamicin has proved to be the most effective regimen in treating postpartum endometritis, especially if occurs after cesarean. The prophylactic antibiotic recommendations is as the following. These are the cesarean cefazolin, first generation cephalosporins. If allergic to penicillin, we can use clindamycin or erythromycin. Operative vaginal delivery is not recommended. Manual removal of placenta is not recommended. Third and fourth perineal tears, we recommend to give antibiotic. Postpartum curettage is not recommended, as well as the cervical cerclage.